Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky. Got my co-host, Dr. Karl Nadolsky. He's the one crashing around in the background over there.
Yeah, I got it. I'm 1 week post-op, right hip replacement, so I'm still supposed to use my walker.
He's a bionic man. He's got two replaced hips. He's a bum. And today we have another special guest, and his name is Dr. Luke Laffin. He's a cardiologist out of the Cleveland Clinic, worked as a protege to the great Dr. Steve Nissen.
Yeah. He came specifically recommended from Steve Nissen.
Yeah.
To talk about this topic today.
Yeah, he's done some cool studies. One of the studies that we actually really wanted to talk about was comparing a statin to some commonly used supplements, and he's also the director for blood pressure management, preventive cardiologist. Very cool guy, smart guy. We wanted to chat with him. So welcome, Luke.
Hey, great. Thank you for the kind introduction. Great to speak with both of you today.
Yeah. What got you into preventive cardiology, like instead of whatever else? How'd you get into preventive cardiology?
You know, I always liked cardiology, and then my wife is a dermatologist, and we met as interns.
Nice.
So we didn't match up in terms of internal medicine 3 years, her program's 4 years. So I had a little gap year before I was going to match for cardiology fellowship. And the world's hypertension expert is George Bacris at University of Chicago.
Yeah.
And so he's been doing a fellowship there for some parts of Chicago for over 25 years. So I was his fellow about a decade ago, did that, loved it, and then was able to continue it throughout cardiovascular medicine fellowship. And then a great opportunity came along in Cleveland, which I've jumped on.
George Bacris, great voice.
Yes.
What is it about preventive cardiology as opposed to doing interventional stuff? What did you like about that?
Well, I think if you sort of look at the tea leaves and look forward, that's really where everything's going, right? We can do all kinds of fancy stuff with wires and catheters as cardiologists, but when you think 10, 20 years in the future, we really would like to see atherosclerosis as an orphan disease.
Yeah.
And there's potentially the tools in the toolbox to do that. Over the next number of years, gene editing, things like that. So I think it's really exciting. And so I like that aspect a lot.
Man, you're speaking our language. I mean,
we love it.
I mean, Spencer was kind of interestingly involved in med school when I was in internal medicine residency down at the Naval Medical Center in Portsmouth. And my mentors often were the cardiologists down there because of a lot of my interest in cardiometabolic medicine. Obviously, I had the interest in endocrinology, but also obesity and lipids, and so they were always really trying to get me to go into cardiology to because I would only do preventive cardiology, and because I'm sure as hell not going to want to cath anybody. I'm not into procedures, so
you will kill somebody.
God, don't say that now. I got fired again.
No, just because you're not very dexter. Yeah, your fingers are so fat.
I still do thyroid biopsies, so now anybody who's ever had a thyroid biopsy by me, they're going, what the heck did I just get into? Thyroid biopsies are easy.
Yeah, your fat fingers. That's really cool. So what are your top recommendations for like preventing atherosclerosis and cardiovascular disease? That's what we should be asking.
The basics, you mean? Like you're asking him?
Yeah.
His fundamental for most
people.
I
want to know what do you tell your patients? What do you do?
So I tell them really it's a three-pronged approach: nutrition, physical activity, and medications. And I show them a picture of, atherosclerosis when it starts. You get your difference between your stable and your vulnerable plaques, and then what it looks like when a plaque ruptures. And so I actually have the same laminated card that I show everyone there. Most people take a picture of it. They're like, oh, I want to show my spouse this. And I tell them, look, you got to do the first two, the nutrition and the physical activity. The third one, the medicines, it's personalized based on risk, et cetera. And so those are the major things that we really stress in this when we see people at Cleveland Clinic or when I see them.
So do you give everybody a statin? That's what everybody wants to know. Are you a statin shill?
I mean, I write my fair number of prescriptions for statins. There's no question. But I only give them if they need them, right? And
Yeah.
oftentimes it's a discussion. The folks that I see, I have an open conversation saying, really, it's not if you're going to get a statin, it's just when we pull the trigger, right?
Yeah.
I mean, anecdotally, a lot of cardiologists, particularly in the non-invasive preventive space, they start a statin in the mid 30s, early 40s. And it's because, number one, we believe in it. But number two, we've seen enough bad stuff happen. And we've all heard about that, 40-year-old dad who just didn't wake up one morning, right? And left a couple kids. And so that's something that we want to avoid. And you have to do all of it, the lifestyle. And if you can get a little help with medicines without any side effects, why not?
Yeah. So, I was just going to say, anybody listening, we get in these arguments with people online about how especially cardiologists, especially the older and crustiest of all cardiologists, and you're a young guy, so it's all right. But basically, there's no discussion. Everybody's going on a statin, and what you're basically conveying on your clinical practice is what should be done as a shared decision-making process. But ultimately, a lot of people, because of probably lifestyles and genetics, of course, too, could end up on one. But at least you're having the discussion and going over the risks and benefits. I like that. What were you going to say, Casey?
Oh, well, now you made me lose my train of thought, but I was just,
whatever.
It doesn't matter. But I think we often talk about obesity in the big picture of cardiometabolic disease, and then includes, atherosclerotic disease. And there is a complex genetic background. And so, people have different family histories, different things that have gone on in their lives, different other risk factors. And so I guess one of my questions, since we're doing this and we haven't gotten to our main focus today, is what does trigger a referral to you as a preventive cardiologist? Obviously, if someone suffers an event, they have rhythm issues, whatever, heart failure, they're going to see a cardiologist. So I see a lot of high risk people. A lot of them already have atherosclerotic disease, and otherwise I'm often kind of playing the role of a preventive cardiologist, but as the endocrinologist, because they're seeing me for obesity, diabetes, et cetera. So I'm always interested in what's triggering your local referrals to a preventive cardiologist.
So there's a couple different pathways. So I'm sort of, my main focus is resistant hypertension. Mm-hmm. So I see a lot of those folks who they just can't get it controlled with their primary care doctor or other specialists. So that's one area. But when we're thinking about this prevention of atherosclerosis, I see a lot of high risk primary prevention. So maybe elevated Lp(a), because I'm very involved in the clinical trial space with that. People, a lot of South Asian descent where, father had a MI at 45, they're in their 30s and they want to make sure that they prevent that. And then a lot of higher risk secondary prevention where maybe they're statin intolerant, they need inclisiran, they need a PCSK9 inhibitor. We see that. And then increasingly in our prevention department, we have a Center for Cardiometabolic Disorders. So a lot of obesity, metabolic syndrome, hypertriglyceridemia, et cetera, and sort of marry those three medications.
Are you working with some of the endocrinologists and obesity specialists there? Because I know some of them too.
Yeah. So we have a specific center for cardiometabolic disease, and one of our cardiologists in prevention, his name is Dennis Brumer. He's actually a board-certified endocrinologist and cardiologist. He was a great recruit for us a number of years ago.
That's intense.
Yeah, I've sometimes wondered if I just wanted to just kind of keep going to school forever or do residency and fellowship forever, that would be kind of the path I'd go.
I think I've seen that guy because I think there's only one in the nation. I'm pretty sure he's the only one.
Is that training to do that?
That's a lot of training. You're just in school forever.
It's true. And he's a great guy, real smart guy.
That's awesome.
It's lucky to have him.
Cool. And part of the reason we have you for today is because of your experience and working with Dr. Nissen, and with like you said, you do a lot of trials. And so, Steve Nissen is globally renowned for cardiovascular risk reduction trials, right? I mean, that's kind of one of his niches that he's famous for. And Spencer, are you ready to introduce why the heck we're talking today? What we're
Yeah, well, why don't you ask?
Well,
I didn't watch this. I didn't watch the
okay,
show.
well, all right. So this is this is what happened, and people are going to think we're just like piling on Peter Attia, and I'm not going to say poor Peter Attia because he's I think he does pretty darn
He's
well
rich.
for himself by
He's
being
rich.
whatever self-proclaimed longevity expert is, but he's a medical physician, and he actually says a lot of good things.
Good
Well,
stuff. Yeah, not
a
bad.
couple of months ago, my family and we were watching this show. It was on Disney Plus with Chris Helmsworth, or Thor, right?
Thor.
You know
Thor.
that guy, Luke?
Yeah.
So anyways,
Good actor.
he was doing this series called Limitless, where he was doing these extreme activities to just better himself, better his life, whatever, maybe pushing the limits of what I would consider evidence-based therapies, but some of it's psychological and whatever. And one of the episodes was about dramatic temperature changes. So he was going to swim in the Arctic Ocean, so that was one of his tasks. And then he flipped the switch to the other way. And he did a little introduction of this guy named Peter Attia. He said, they hooked me up with this longevity expert, Peter Attia, who's going to take me into one of these really, really hot saunas. And they started talking about heat shock proteins and how heat shock proteins can dramatically reduce the risk of atherogenesis and cardiovascular risk. And then in the sauna, Peter Attia made the quote, and I saved it, and I'll share it when we share this podcast. He says, doing this frequently can reduce your risk of cardiovascular events by 50%. And he said, way more than any drug we could even imagine. And then he went on and he said 65%. I think he said for Alzheimer's disease. And I thought, what in the world is he talking about? I was like, there's no way there's evidence for that. So we started looking it up. And, I found probably what he's kind of referring to that I sent you guys. But it is far from a randomized controlled trial, but it was it's an older started study in Finland, a prospective cohort study of people who use really high heat saunas frequently, and there was a correlation, with reduced cardiovascular events and mortality.
Basically, people that used it, not randomized or anything like that. They didn't intervene and send them to start getting saunas. People that just tended to use those tended to have lower risks, right?
And so he's making this claim that using a sauna reduces cardiovascular events better than any medication we could ever imagine. And I thought, my God, now he's telling people this, and we have no randomized controlled trial data. Maybe there's something to it. So I don't want to totally dismiss it, but boy, I don't think we should be telling people saunas are better than medications. But we thought, what the heck, we're going to talk to some cardiovascular outcome trialists who might know what the heck is going on here.
So yeah, I would like to hear why do we have trials, Luke? Why do we do randomized controlled trials as opposed to just
observational studies and cohort studies, etc. And the reason is simple, is that there's certain things that we just cannot control for without the power of randomization. And that's oftentimes true in association studies and observation studies like the Finnish study that you were referring to. But I mean, you can see these all the time when we look at, coffee consumption and cardiovascular mortality, or alcohol consumption, etc. And they catch a lot of headlines, right? And they can show some pretty profound benefits. But when you actually get down and you do blinded randomized controlled trials, oftentimes those signals go away because there's certain things that we can't account for. So-called sort of confounding factors.
Yeah, one of the famous ones is actually cardiovascular arrhythmias, right? That's your arena, where they thought that giving these antiarrhythmics was a good idea until they finally actually.
Exactly. And I mean, I think that, there is some data that saunas, they lower blood pressure and, certain biomarkers and all of that. So I'm not anti-sauna.
No, and neither are we.
But I that clearly that statement is hyperbolic, and that's probably why the producers ultimately put that on the show, right? Is to say that, because unfortunately, the cardiovascular medicine and cardiovascular clinical trials are littered with examples of early stage studies that showed surrogate endpoints or biomarkers that suggested benefit. And then when you actually put it to the test, that doesn't hold up. And it's a good thing that we have those tests, because we don't want to do things that are, not helpful, but even could potentially harm people.
Yeah, exactly. So do we actually have drugs that are been studied that are actually pretty good at reducing cardiovascular
and people are
risk?
very interested in kind of these, we always talk about these relative risks, and that's confusing for absolute risk, and the numbers needed to treat, and of course it has to do with baseline risk. I don't know if you feel comfortable kind of trying to explain that in a lay perspective, so people have an idea of what kind of numbers we're even talking about when we talk about 50% reduction, because that's sounds
Yeah,
great.
well, let me give some examples. I mean, so as much as your audience may understand, so there's other medicines to lower cholesterol on top of statins, and those have been studied more recently. And the first set of those were not FDA approved until they showed not only that cholesterol and or other biomarkers were improved, but they actually reduced hard cardiovascular endpoints, so strokes, heart attacks, need for any type of revascularization. Some of the best examples of those are the monoclonal antibody PCSK9 inhibitors, so evolocumab and alirocumab. And when you look at those trials, they enrolled generally higher risk individuals, but when we look at the number of individuals that actually had one of those cardiovascular events, it's in about a little bit over 10%. Okay, when you take the drug, that's in the placebo arm. Okay, in the people that actually got the drug, you might get 2% absolute lowering, but a much more significant hazard ratio in terms of relative risk reduction, right, in the 0.85 range, et cetera. So there's a very big difference. And the issue that we're running into in cardiovascular medicine is that our therapies are so good now that we need to enroll tens of thousands of patients to oftentimes see a signal. So that's what we're sort of looking at when we think about these absolute versus relative risks.
Okay, and this kind of gets into your study that you ran. Why did you? So tell us about this study that you did that compared statins to supplements, and why you guys wanted to do this, because this is interesting.
Sure. Yeah. So this was a great study that I was really happy to be a part of. It's called the supplements placebo or rosuvastatin study, and it was really done to all these supplements out there are marketed for some type of cardiovascular disease prevention, or they say heart health or heart risk reduction. And these are all really coded terms that don't mean much, but they don't have to, at least from a supplement perspective. So what we did was we randomized 199 participants to either 5 milligrams of rosuvastatin, which is the lowest dose of rosuvastatin, but technically a moderate intensity statin, or to placebo, or one of 6 supplements. Your ones like garlic, red yeast rice. We had a fish oil supplement on there. We had turmeric. We had cinnamon. All things that, when you look at market research, they're being taken for heart health reduction. And what we did was we just compared. The LDL cholesterol lowering was the primary endpoint, compared with each of these supplements. And we did it over patients took the intervention for a month, and then we measured the change in LDL cholesterol, which was the primary endpoint. We also looked at markers of inflammation like CRP and other cardiovascular biomarkers like HDL cholesterol, triglycerides, et cetera. And the take-home point of the study was, 5 milligrams of rosuvastatin, vastly superior in terms of lowering LDL cholesterol, which, as you know, is causative of atherosclerosis, compared to placebo and any of the 6 supplements. And interestingly, we saw certain supplements actually had negative effects on certain biomarkers, like garlic increased LDL cholesterol.
I saw that. I was like, wow.
That's going to upset a lot of people.
And the issue is, and it's a supplement, it's garlic. Yeah. It's not actual garlic that we ingest necessarily. And so it just speaks to, these supplements are not well regulated. If we have tools to lower cardiovascular risk, and the important part about who we enrolled is this wasn't, young folks like us on this call, right? These was people at elevated risk for over the next 10 years of a stroke or heart attack. And so that's why we couldn't do a long-term trial, because it would be
unethical, basically. Yeah.
Unethical.
Yeah, unethical. Yeah.
And so these are people that by the guidelines should be having a discussion with their doctor about starting cholesterol lowering medicines.
So this kind of gets back to the point. So you got some marketing person out there saying garlic helps with cardiovascular disease, and maybe I'd have to look at some of the observational data out there. It looks like those who take more garlic supplements reduces their risk by XYZ. And then you actually do a trial, and you weren't looking at hard outcomes, but you're looking at the biomarkers that we know at least are involved in the process. And it shows that, hey, this may have actually worsened certain things, whereas the tried and true pharmaceutical statin. Actually, the one that surprised me the most was the red yeast rice.
That's a statin.
It has monocolin K, which is like a lovastatin, but they've been removing this monocolin K, and maybe you know about this. Some of them just don't even have any much of it in there. So this gets into the whole, like, I don't know how these regulated. You don't know what you're getting,
or
like,
they
unless
did it
you
on purpose, because of so many people are anti-statin, and they were like, "Wait, I was taking this because it's not a statin."
I don't know.
And we all say, "Actually, it's a statin."
Luke, do you know much about the whole monocolin K stuff? I mean, you might have had to.
Yeah, exactly. I mean, really, sort of anything in red yeast rice that's purified, it's a monocolin K. It's essentially lovastatin, right?
Yeah.
I mean, it's just a dirty form of it, shall we say? There are studies that show reductions in LDL cholesterol with red yeast rice, but that was sort of the point of the study, was if you buy this medicine over the counter, you have no idea what's in it, right? You could buy the same medicine 1 month and it's the same bottle the next month, and we don't know. They may have changed the formulation. They don't have to do any testing. They don't have to tell you that. And we have to remember too that these supplements, they're not benign necessarily.
Right.
Thousands of emergency department visits every year for supplement use.
We tell that to people all the time. I mean, like, if you're taking something because you think it's doing something, if it is doing something, that means it's a drug, and it can do something good or bad. And so that means it's a drug.
It has effects.
Let's be clear.
Right,
Supplement has an effect. Yes.
What I tell all my patients is, particularly when it comes to blood pressure, and I get asked at least once a week, "Oh, doc, is there any supplements I should take after we go through that whole spiel that I talked about?" And I tell them, I would like, number one, things like your blood pressure and your cholesterol to be under control. That's our number one goal. But our number two goal is to do it on the least medicine possible.
Mm-hmm.
So if it takes one medicine, great. If it takes three, not as good, but we'll do it, right? And most people buy into that.
Yeah, that's great. And because we get, Spencer, you saw that, the person that's like anti-medicine for whatever, thinks we're all just getting paid by giving people medicines and not helping with diet and exercise. And it's like, you must not know who you're talking to. Because we always want to do everything without medicine if we can get away with it, but we want to reduce people's risks and improve their health one way or the other.
I just want to know, at a resistant hypertension clinic, how many cases of primary hyperaldosteronism?
I was waiting for this. Spencer's obsessed with my hyperaldo diagnosis.
He must have a high prevalence.
You think?
Yeah, well, I mean, you just have to, honestly, any physician that treats hypertension is going to have a high preprevalence.
Boy.
The problem is we don't check for it, right? Just do the test. I mean, I actually had a conversation with a colleague this morning, a young woman on losartan hydrochlorothiazide, and I say, well, you should just check an aldo-renin ratio, right? And he's like, well, don't they interact with it and change the assay and, change it? I'm like, it doesn't matter. Just screen, okay? Maybe you'll get a false negative, but it's not going to cause a false positive with those. Just screen and then think about it later. That's what I say.
Perfect. That's great. I love it.
Yeah, we probably have to get our primary care friends to do even more of that, and we all should be doing more of that. Well,
that's a very little known thing. I only knew it because I was in residency and you were in endocrine, and I was laughing. I was like, all right, well, I'm just going to start. You sent me some papers. I'm like, oh man, the prevalence is kind of high, and we're given spironolactone as like the last thing, and that's the one thing that works. It's like, okay, that makes sense to me. Anyway, people listening, like, what are you guys talking about? Anyway,
well, let me circle back a little bit, to this whole sauna thing. Because, we talked about, all right, so we don't have, we have this observational data. There are some hypothesis generating thoughts, right? So there's some thoughts that, well, maybe it's good for us. I don't know. Do either of you guys know this heat shock protein issue? Is there really evidence for that? Because they made a big deal about it in the show, and I just don't know.
A lot of biological plausibility, but it's not. It's one of these things where you start getting into the weeds of the mechanisms, and
so so then there's that big observational cohort that looks like it has some correlation, right? And then I think I sent you guys both. There was a randomized controlled trial. Now this gets into like what we talk about, the surrogate markers of the biochemical stuff. The title was effects of regular sauna bathing in conjunction with exercise on cardiovascular function. It was a multi-arm randomized controlled trial, and essentially they compared the effects of exercise and sauna bathing to regular exercise by itself. They had almost 50 people around age 50. They already had low physical activity levels and at least one traditional cardiovascular risk factor, randomized to exercise and 15-minute post-exercise sauna, exercise, or just control for 8 weeks. And it looks like they had some slightly improved blood pressure, maybe some cardiorespiratory fitness stuff, maybe even like some lipid things, in the sauna compared to no sauna after exercise. But I don't know. I feel like, that at least suggests some, surrogate marker benefit that certainly seems like maybe it could lead to improvement. I just don't know how applicable any of this stuff is, and they're putting it on mainstream stuff.
I just want to know if Dr. Laffin is having his resistant hypertension patients going into a sauna.
To go into a sauna?
If he is, then I'm going to start recommending it.
I'm not dissuading them from using it if they ask, but it's definitely not part of my spiel with them saying that, you need to do this. Look, this is something where it's generally for patients with stable hypertension or stable ischemic heart disease, can probably do it safely without any harms. Could there be benefit? Yeah, there definitely could. There is biological plausibility, probably lowers blood pressure a little bit, probably improves cardiorespiratory fitness to a little bit if it increases your heart rate as much as they allude to in some of those observational studies, up over 100 beats per minute. Is it replace exercise? No, there's no data obviously to support that. So it's not something that I'm going to commonly recommend, but I don't see any harm to it for the vast majority of people.
Now, unless, so I will say this. So Luke, did you play any sports in high school, college, or anything like that?
Yeah, I played.
Oh, really? Did you go to college and play basketball?
I did not play in college. I played in high school. I'm from Calgary, Canada.
Interesting. Cool. Okay. Well, so I wrestled at Michigan State. Spencer played a little football, wrestled, but he was a heavyweight, so he doesn't count because he didn't care about this stuff. But we would sit in.
I had obesity.
I'm not supposed to say that because I don't think we were supposed to back then. Anyways, we used to sit in the sauna after our practices. So maybe that was really good for our. Maybe it was good for our cardiovascular health, except that we were doing it to get dehydrated and make weight. So I'm not so sure that was healthy.
Yeah. Oh, Canada. That's we see all the old guys in the gyms. They're all, basically naked. It's there. Maybe it's really good for us. I don't know.
I guess my point is, with Peter Attia, I don't like these big, huge claims being made, telling people how to reduce their cardiovascular risk and improve their longevity without any data. And yet what it ultimately turns into is the kind of this anti sort of real science giving real known, medical advice. Like we have nutrition data, we have exercise data, about as good as it gets for longevity and cardiovascular risk. And then we have some medications. I guess I just don't understand why they can't talk about things like saunas in a more reasonable way, but I know that doesn't make the money and it doesn't make the show. Yeah,
it's marketing. It's all marketing.
Crazy.
The best example that I have, when we talk about diet with my patients, I tell them, there's 1,000 books by 1,000 different cardiologists, endocrinologists about heart healthy diet. Go on Amazon, you can do it. 90 to 95% of what they say is exactly the same, and you guys know that. But they got to sell their books somehow. So the 5 to 10% that different, don't eat this oil, or eat this on Sundays every week. That's how they put on their cover, and that's what they sort of get you hooked on, because it's not sexy to say, oh yeah, eat a balanced diet. yeah, every once in a while you can have some red meat, right?
Yeah.
Oh my God, Luke is definitely in our circle. My God, he speaks our language. You are right on the money.
He's a reasonable. He's a reasoned shill, a nuanced shill.
Appropriate, reasonable, basic lifestyle, evidence-based lifestyle advice. We've all gone broke because of it.
Nice. Thank you so much for coming on. It's a nice little chat. We might have you on in the future to talk about more stuff about hypertension, but appreciate it. Thank you.
Hey, thanks so much, gentlemen. Appreciate it.
Anybody out there has a family member struggling with hypertension or whatever, and got a kick out of this podcast, make sure you share and give us a nice little review.
Oh, does Luke have any social media or anything else we need to?
He's on Twitter. I just added him on Twitter. If you want to
check out his Twitter.
You want to yell at Luke on Twitter? Go ahead.
Oh yes!
Oh God!
See that?
I can imagine. Here's our outro.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.